So now we will be talking about, we will continue our discussion of the core elements and principles of research ethics. And the first step will be benefit-risk ratio. So guidelines say that risks and burdens must be minimized. What do we mean by that? It means that as much as possible, you want the risks and burdens to be as minimal as your methodology will allow. So for example, if you can do with 10 mLs of blood, why will you get 20, for example? All right. So if you can make the research participants go to the clinic once a month, why do it twice a month? So if you're getting comparable results anyway, and it doesn't affect the scientific validity of your study, so you would want to lower down the risk and the burdens. Next, research guidelines say that risks to subjects and others should be delineated and quantified. This means that you don't only specify what the risks are, but you also want to specify as much as possible and as much as you know based on the literature or previous studies on what are the probabilities of such risk and what is the magnitude of such risk. And you would want to do the same thing with benefits. Right, so the benefits to subjects, but also most probably the benefits to the community should be delineated and quantified as well. Right, so you want to say that. So researchers should specify what are these benefits. Of course, the benefits to society should be something very clear. I mean, that your research really has some societal benefit to it, some societal value to it, but also for the research participants, right? And by benefit, we refer to the direct benefit is what they get by being part of a study and taking and having this particular intervention, right? So what these benefits are ought to be delineated and quantified as well, as we did a while ago with risks. And that the level of risk must be justified, right? So so a study would have risks and benefits, and the rule of thumb is the risks should not outweigh the benefits. Ideally, you would want the benefits to outweigh the risks, right? So if you for example imagine risks and benefits as two baskets. And then you're weighing these two baskets. You do not want the risk basket to weigh heavier than the benefits. You would want them to, at the very least, to weigh in a comparable manner. If not, or better yet, if the benefit basket weighs heavier. But we know, the devil's always in the details. And when we talk about risk and benefits, we talk about these things. I will go back to what the Declaration of Helsinki says about risk and benefits. But I just wanted to show you this first. On the risk basket, you would have risks due to the intervention and risk due to study participation. But then the benefit basket will have direct benefits. As we said a while ago, direct benefits refer to the benefits incurring to research participants because of the study intervention. And then there's also inclusion benefits. This refers to benefits that accrue to research participants simply because they're part of a study. And there's also benefits to society. The overall, the bigger picture, the overall reason why you're doing the research. Just by stipulating what benefits are that can be put part into the benefit basket and what the risks are that can be put into the risk basket, we already see that the benefit basket usually weighs heavier, especially when we include benefit to society. But then the question is it fair to say that is it fair to say that we should include such big benefits in the benefit basket if doing so would mean that the benefit basket will always be heavier, and thereby minimizing probably real risks in the process. This is an important question, especially for research ethics committees, because they're the ones who would actually do the swaying. So what do you put in the risk basket and what do you put in the benefit basket, such that the weighing of risk and benefits is something that is something that's being done in an ethical manner and justifiable manner. As I said a while ago, I want to show to you what Declaration of Helsinki says about risk and benefits. So Helsinki says that in medical practice and in medical research, most interventions involve risk and burdens. Medical research involving human subjects may only be conducted if the importance of the objective, that refers to benefits, outweigh the risk and burdens to the research subject. Now, this is a terminology. This is a terminology difference. So, for example, we have SciOMS that uses the term benefits instead of importance of the objective. Because when we say importance of the objective, that simply refers to balancing societal benefit to risks, right? But what exactly? So again, we go back to the question: what do we put in the benefit basket, and what do we put in the risk basket? It also says all medical research involving human subjects must be preceded by careful assessment of predictable risk and burdens, with foreseeable benefits to them and to other individuals. And this is what we said a while ago, that the risk and benefits must be properly identified and delineated and as far as possible quantified. And measures to minimize the risks must be implemented. The risk must be continuously monitored, assessed, and documented by the researcher. So yes, and also confirmation of what we said a while ago, that as much as possible, as much as your scientific methodology allows, you would want to minimize the risks, right? That you don't want to expose your research participants to unnecessary risks, and maybe also not to expose them to additional risks. Okay. Example, taking of blood tests and or use of more of patient's time. This is the example I gave a while ago. If you can do with less bloodletting, why would you get more? If you could do with fewer visits, why would you ask for more? Okay, next is what we call independent review. By independent review, we refer to the task of research ethics committees. And also for interventional studies, but also for some kinds of observational studies, a research ethics committee review would be necessary. So guidelines to say that every interventional study must be submitted to the research ethics committee for approval. So what do we mean by interventional study? It's a study that requires some kind of procedures and or interventions. Next, guidelines say that research protocol must be submitted before the study begins. That the ethics committee should have read through the protocol and should have evaluated it before and have given their approval, before the study begins. The research ethics committee must be transparent and functioning, must be independent of the researcher, and undue influence qualified. And also, the standard operating procedures of research ethics committees must be known, to the researcher and other relevant stakeholders, right? So an ethics committee procedure shouldn't be a black box where no one knows what happens in it except the research ethics committee. So this is simply what is meant by being transparent. Ethics committee must be transparent, but an ethics committee must also be independent. It means that there shouldn't be any conflict of interest between being a member of an ethics committee and being part of a study, for example, no matter what that being part of a study means. Right? So you want to remove any kind of conflict of interest, at least in the evaluation of a specific study. right? So if a member of an ethics committee is part of a specific study, that member cannot be part in the evaluation of this study. It doesn't mean that the ethics committee member cannot be part of any other kind of evaluation after that. And so long as there's no conflict of interest, then that member can be part of the study of the evaluation, of course. And then any undue influence must be qualified. For example, it must be transparent whether an ethics committee receives payment directly from the sponsors or researchers, or if the ethics committee is an institution that's being maintained, by the sponsoring organization. I mean, such things need to be transparent and as much as possible addressed. Research Ethics Committee must have the right to monitor studies. They must have the right of oversight to know what's happening, to know of adverse events when they happen, to know of severe adverse events when they happen, and what the procedures are to address such events. Also, the protocol of the study cannot be amended without the explicit approval of the Research Ethics Committee. And then lastly, ethical standards outside the country of the sponsor should be no less stringent. This can be a real challenge. And number one reason could be lack of resources, right? So when it comes to being stringent, it's not only because there are not enough experts, but also because it could be a simple lack of resources, So think, for example, of long-term monitoring or monitoring a study. An ethics committee can be so overburdened that even if they want to do monitoring, they're not able to do it because they're simply overburdened and there's not enough resources to do it. This is a result from an older study back in 2002, just for us to have some sort of an appreciation or an understanding of the kinds of problems that ethics committees encounter. So this is a study on ethics committee members of cancer clinical of a research ethics committee that reviews cancer clinical trials. So in this study, the researchers showed that between 15% and 34% of IRB or Research Ethics Committee or REC members reported feeling less than fully competent at evaluating various aspects of phase 2 protocols. So if they feel less than fully competent, that kind of puts the safeguarding task of research ethics committees at risk. And a few IRB members reported weighing risks and benefits in a systematic manner. So we just said that research that the weighing of risk and benefits is a task of research ethics committees. But in this study, it shows that at least in this for this particular research ethics committee, members felt members would not even weigh risk and benefits in a systematic manner. Why that is so probably needs a little bit more exploration or explanation why. Rather than weighing risk and benefits in a systematic manner, they would rely on global impressions or preferred to leave such matters to the IRB as a whole or to their patients. So what does it mean? It means that some of these members would, instead of coming in prepared to a meeting, weighing risk and benefits in a systematic manner, they would say, okay, let's just wait and see what happens once we start evaluating a proposal in a forum, once the research ethics committee is in forum, right? Or even worse, some ethics committee members would say, well, that's something that I would leave to the patients by making sure that that is stated, for example, in the informed consent sheet. Okay. An important conclusion will be a substantial minority of IRB members believe that trial protocols provide too little information. right? So this tells us that there might be some areas for improvement in terms of what is stated or stipulated in the protocols to make sure that ethics committee members are able to fully appreciate or understand what the study is about and what the actual risks and benefits are for them to actually do the risk-benefit assessment. But also, it also tells us that the research ethics committee members would probably need some kind of a refresher on what it means to systematically assess risk and benefits. Next will be the requirement of informed consent. So by informed consent, we refer to three things, in fact. We refer to provision of information. We refer to making sure that such information is comprehensible. And we also need to make sure that the decision to say yes or no to be part of a study is something that's being done voluntarily. Yeah, so we have the information bit, we have the comprehension bit, and we have the voluntariness bit of informed consent. Yeah. So informed consent forms and procedures must be culturally sensitive. Yeah, it means that you would want to adapt the informed consent form in a manner that is respectful of the culture and understanding of the culture, of course. But also procedurally, it should be culturally sensitive as well. So, for example, if the culture requires some kind of consultation first with the community head, then therefore the informed consent procedure should include that in the process. Right? Take note that doesn't mean that anybody else can provide the consent outside of or other than the research participant. The informed consent must be provided only by the research participant. Other consultations might happen, right? But the decision must be made only by the research participant. And in cases of persons unable to consent, then the legal representative. So consent must preferably be in writing. Participants should have the opportunity to ask questions and receive truthful answers. The participants should be provided time and the opportunity to ask questions. And that these questions must be answered reasonably. To help the participants make the decision. Legally authorized representative must be present in cases of individuals unable to consent, such as, for example, children. But at the same time, if children are shall we say, old enough to be able to understand research and its procedures, then you would also want to explain to the child as much as possible what the research is about and what participation entails, and also ask the assent of such a mature child. So again, we have here informed consent. So there's, of course, the provision of information, which should lead to knowledge, to understanding what the research is about. And there's also the there's also voluntariness in informed consent. So after you have provided information and after there's comprehension, so you want to make sure that the informed consent procedure is being done in a manner that's respectful of the freedom of the person to decide. Failure to respect knowledge can be caused by, for example, deception. For example, if you downgrade risk and highlight the benefits, that can be kind of deception, right? Or it could also be withholding information. Now, you don't tell them that they will undergo this procedure, then that's withholding information. Then again, that affects the knowledge aspect of informed consent. But when it comes to the voluntariness aspect of informed consent, then this can be affected by coercion. If our research participants being forced to participate, but this can also be caused by undue influence. What do you mean by undue influence? This refers to, for example, if you ask you as the attending physician of a patient tells the patient, well, if you do not form part of the study, then maybe I cannot attend to you anymore. I mean, or that say, well, yeah, I'm sure the study will, participation in the study will benefit you, because you automatically already have this relationship, this fiduciary relationship with the research participant as the attending physician. So whatever it is you say as an attending physician automatically has some form of credence, but that's not some, and putting that within the context of research might be abusing this fiduciary obligation, this fiduciary relationship, right? And that can be a form of undue influence. But undue influence can also refer to undue inducement. When a research provides so much money, for example, or gifts or services, such that the person is already unable to properly decide whether to be part of a study or not. So think of a person who is financially burdened, and that person who is desperate for money might not anymore think of the risks of the study if he offer him or her too much money. So in which case then the person is already unable to properly decide for himself or herself whether to participate in the study. And this is very crucial, especially in studies that involve risks, such as studies with certain levels of toxicity. Right. So these are so informed consent, as we have seen, this can be affected by several factors, and if these factors that you see in red are present, it could be that the informed consent process is considered, or the informed consent form, the signed informed consent form, might be considered invalid. Okay, so just to go through what the guidelines say, this is according to Declaration of Helsinki. As what we said a while ago, that giving of informed consent must be voluntary. So consultations might happen with family members, with community heads, etc., etc. But then it's only the research participant who should give his or her informed consent. Sufficient information. What do we mean by sufficient information? We said already a while ago that this means giving enough information for the patient, participant, or simple participant to make a rational decision, a rational understanding of what the study, a rational appreciation of what the study is all about. But here, the Declaration of Helsinki is somewhat prescriptive. It tells us what should be the minimum content of an informed consent form or information sheet. So Helsinki says that the following should be present. It says the informed consent sheet should contain the aims, methods, sources of funding, any possible conflicts of interest, institutional affiliations of the researcher, the anticipated benefits and potential risk of the study, and the discomfort it may entail, post-study provisions, and any other relevant aspects of the study. So the potential subject must also be informed of the right to refuse to participate in the study or to withdraw consent to participate at any time without reprisal. Special attention should be given to the specific information needs of individual potential subjects. As we saw a while ago, it has to be culturally relevant but also respectful of the differences, between people. And because again, the goal is to ensure comprehension. So again, ideally, this is something that must be in writing and must be formally documented and witnessed. Helsinki also talks about the need for a specific opportunity in time, as we mentioned a while ago, but it also talks about renewal of informed consent. And this can happen if there is a substantial change in the conditions or procedures of the research, or if new information becomes available that could affect the willingness of participants to continue. Now, so if there's new information that changes the nature of the research, such as, for example, changes procedures, or if new information comes, for example, if the benefit-risk ratio has already changed, or simply because time has elapsed, like, for example, 10 years have passed, and the participants don't even know that their data is still being used for research. So that is enough indicator that there might be the need to renew informed consent. This is an example of a problem of informed consent that we see in the ethics literature, and it's called therapeutic misconception. What does that mean? It means that there's a widespread problem when it comes to securing informed consent in research, especially in health research, because research participants tend to think that inclusion in health research is done primarily to benefit them in terms of health. That is, that their inclusion in a study is mistakenly interpreted as that the inclusion is something therapeutic. It may or may not be the case that the inclusion in a study might be therapeutic. But we need to make sure, researchers need to make sure that research participants understand that a research study is meant primarily to find results, to answer a research question, right? Because making participants think, or allowing the participants think to continuously think that the inclusion is primarily for the therapy would probably be misinforming them. And so they may or may not benefit from research. We don't know precisely because it's research, right? And that is why this therapeutic misconception must be properly addressed through proper informed consent procedure. Example of therapeutic misconception. Researchers ask these set of questions to research participants. You know that this is research. Yes. You know that your inclusion in an arm is like flipping of a coin. You go to one arm and the next in a randomized manner. Yes. So you think that your inclusion in research is there because it benefits you therapeutically, and they still say yes. So it just tells us how much effort must be put in place to make sure that this is addressed. Next, guidelines talk about require, of course, respect for participants, and this refers to looking into participant safety, that the health of the participants are monitored to make sure that the harms are minimized. For example, in clinical trials, then you would have a safety and data monitoring board that reports to the researchers or the PI and or the ethics committee, that there must be explicit criteria for changing dose or procedures for stopping, that all reasonable means should be taken to ensure safety of the participants. So if there are adverse events or serious adverse events, then what will be the protocol to make sure that the research participants are not exposed to any more additional risk? There should be adequate facilities to protect from injury, disability, or death. Right. So this means, for example, making sure that you would know what to do if there's injury, disability, or death, in terms of compensation, but also medical attention, but also insurance. Right. Respect for participants also refer to privacy, respecting privacy and confidentiality. At the most basic, confidentiality procedures must be effectively implemented. and the subject's research data must be protected. Yeah, so this means limiting who will have access to the data of the research participants. This means even within, if for example you have a big research group, who will have access to the data? It should only be individuals who really have something to do with it, right? Not everyone in a really big research group should have access, right? But also, how are you going to protect it? Are you going to put the data under lock and key? Under lock and key physically or digitally, and up to when, right? Next, it also research for participants are also referred to compensations. So in relation to what we said a while ago, subjects harmed due to research must be appropriately compensated and treated. Appropriately compensated, what that means has to be specified, of course, per study, right? And they must be also appropriately treated, again, specified per study, right? But basic should be that these must be put in place. Now, in relation to respect for participants, there's what we call ancillary care obligations. What do you mean by ancillary care obligations? We refer to, this refers to the care provided during the research when researchers discover conditions other than those under study. So, for example, if a researcher researching on drug-resistant tuberculosis requires HIV testing, and in the process discovers that some of the research participants have HIV, that researcher or this research organization that required HIV testing for a study on drug-resistant tuberculosis has an obligation to do something with that information, right? So whether that's informing the research participants, of course, with their consent, informing them of the result, or referring them to a healthcare facility, whatever it is. Now, but that responsibility of informing the research participants, for example, of their HIV status, or referring them to a healthcare facility, is what we call ancillary care obligations. Now, it's not very easy to identify when a researcher has an ancillary care obligation. Now, but Belsky and Richardson came up with some form of proposal, on how to identify this. Of course, it's still very difficult to identify it, but we can go through their proposal. When we talk about ancillary care obligations, we talk about that which is not required to make a study scientifically valid, to ensure a trial's safety, or to redress research injuries, but still it's a responsibility of care anyway. And Belsky and Richardson presented what they call a partial entrustment framework. It's a framework that's dependent on the relationship between participants and researchers. It simply means that there is that participants entrusted to a limited extent their health to researchers, and therefore a certain kind of relationship now exists, and therefore a certain kind of responsibilities now exist. So the first step in their proposal is to identify the scope of entrustment. What is this relationship, and the strength of the duty of care. So yeah, given this relationship, do these researchers really have a duty of care towards these participants? So first question would be, is the claim within the scope of entrustment? That is the claim of ancillary care within the scope of what the participants entrusted to the researchers? If the answer is no, then there's no responsibility to provide ancillary care. But if the answer is yes, then researchers would also want to ask the question, is the claim sufficiently strong? Is the degree of vulnerability, what is the degree of vulnerability? What is the degree, what is the depth of the relationship? What is the degree of gratitude? What is the degree of dependence? What is the importance of reasons against provision of ancillary care? So simply put, for example, if you're a researcher doing an intervention study on a study drug on this set of research participants for like 2 years, you have a stronger duty of care than a researcher doing an observational study, even on the same set of people for like, say, I don't know, 2 months, right? But also the duty of care increases, for example, as we see with the degree of vulnerability. So the ancillary care obligation of a researcher, and also the scope of entrustment, is stronger if the researcher goes to patients of a specific disease in a low and middle income country where people do not have access, as opposed to patients in a high income country who has regular access to therapy, so on and so forth. Now, after identifying, of course, the strength, if the answer is still yes, then researchers have the responsibility to provide ancillary care. So this is a hypothetical example, but we can also look into the example I gave a while ago, drug-resistant tuberculosis and HIV. So in this case, this is a trial of antimicrobials for sexually transmitted diseases in a developing country. While performing clinical examinations on female patients to check for sexually transmitted diseases or side effects of the antimicrobial drug, researchers are likely to discover many women with vaginal candidiasis. More than half are likely to be suffering from the results of poor dental care and hygiene. What care should be provided for these problems? The vaginal candidiasis, this is clearly within the scope of entrustment because the diagnosis results from examinations essential to the research. The underlying duty of care also seems strong because untreated candidiasis will greatly affect their well-being, and treating it is relatively cheap and easy. Conclusion, using this framework, researchers ought to treat vaginal candidiasis as an ancillary care obligation. How about the dental problems? Well, no. So dental problems are not within the scope of entrustment. If we assume that the poor dental hygiene is apparent and casual observation, its diagnosis would not result from exercising the permission participants granted on entering the study. The question of strength does not arise. Okay. Second to the last, because we still have one more slide after this. Vulnerable population. So guidelines talk about principles that should be put in effect when vulnerable population, or shall we say vulnerable people, are subjects of research. What do they mean by vulnerability? It means that people are vulnerable when they have more susceptibility or probability of being harmed or burdened. So for example, children are naturally considered as vulnerable as opposed to healthy adults, because children are more likely to be harmed easily given certain procedures than healthy adults, for example. So generally, safeguards must be put in place to protect the vulnerable depending on their particular circumstances. And for persons who are not able to consent, this means consulting the legal representative and requiring some kind of authorization from this legal representative in writing. At the same time, and we've said a while, we have talked about this in informed consent, that assent of the actual research participant who's unable to give consent, that assent is secured and respected in case that is possible to secure, and that the research of comparable effectiveness cannot be carried out on individuals capable of consent. That means research on vulnerable individuals are done so only because it is needed to gather data relevant to their population. If that same research can be done on healthy individuals or individuals without the same vulnerability, then that research must be done on individuals without the same vulnerability. That means you do not, simply put, we do not unnecessarily expose to unnecessary risk individuals with vulnerabilities. Okay? And then emergency research. In case when prior consent is not possible, participants or the legal representative must give in information as soon as possible, and consent must be secured for continued participation. Okay. Lastly, and this already borders on what we call research integrity, and this talks about issues such as publications, etc. So conflict of interest, sources of funding, and institutional affiliation must be declared in publications. If necessary, if required, research must also be registered in a public database such as clinicaltrials.gov or UDRANET. Publication and dissemination of research results must be done. And also now we have a problem of, well, the problem of publication bias is not new. This means that there has been a bias towards positive results, while negative results are not published, if at all. But then for clinical care, both positive and negative results are important, because we need to know what works and what doesn't work. But also for research, you don't want to replicate research that doesn't work just because you didn't know or because negative results were not published, right? Lastly, guidelines also say that publishers should retract any article that contains falsified or fabricated data or have been based on unethical research. In terms of falsified or fabricated data, there is no discussion on whether that should be retracted. Of course, they should be retracted. But how about data that is based on unethical research? For example, the research where there was insufficient informed consent. Should such data still be used? And if that data is not used, aren't researchers also how do you call this? Aren't we wasting data, precious data, and therefore commit more injustice? So I'm not saying that unethical data unethically gathered must be used, but I'm saying that there's a whole discussion around it. Okay, that will be everything for now, and thank you very much. Thank you very much for listening, and I hope this lecture will be useful for you.